Welcome back, everyone. So I think we have a short 45 minute session on pediatric and neonatal EEG. I know this is not usually sufficient to understand, but we'll try to focus on those things which are little different from older children or adult EEGs. So I'll briefly take you through the maturation of EEG, what is different in young children. So typically below 1 year is the period which is little different from older children EEG. Above 1 2 years, it's very much same as any other adult EEG that you have seen today, and little bit on neonatal EEG. So in infants and children, the maturation of these components happen in a very predictable manner. So sometimes you can just look at the EEG and guess the age of the child also. So to that extent, some of the background elements are quite predictable. And you should know what are the normal frequencies or background rhythms expected for that age, and some of the normal variants in awake and sleep states. So same as in older children or adults, the background organization, there is an anterior to posterior gradient in awake state and sleep also. So the gradient is in terms of amplitude and frequency, and this gradient from anterior regions to posterior regions can be appreciated in a infant beyond 3 months of age. So if you are able to see that on EEG, if there is anterior to posterior gradient, the child is at least 3 months old, you can say that, right? So this starts at 3 months. So 3 months is a landmark age you need to remember. And the background elements are same, like instead of alpha in younger children, we just call it as posterior dominant rhythm, but because below 3 years you may not have alpha. Then central mu and frontal beta activity. So background description same as in older children. This is an older child with good PDR and alpha attenuation and eye opening, but along with the posterior dominant rhythm, you also have some central rhythms like mu or central dominant rhythm itself, and the frontal beta rhythm. So coming to PDR, how is it different in young infants as compared to older child? So remember, this 3 to 4 months is a landmark age. Lot of things start changing from 3-4 months of age. So at 3 to 4 months of age, the posterior dominant rhythm is of 3 to 4 hertz frequency. So remember that one number, 3-4 months, 3 to 4 hertz posterior dominant rhythm. By 1 year, this changes to around 6 to 7 hertz in the theta range. PDR. Then by 3 years, nearly 50% children will have a alpha range PDR, posterior dominant rhythm. By 8 years, most of them, or more than 80% of children will have alpha rhythm, 8 hertz rhythm or above. Okay, so remember 3 to 4 months, 3 to 4 hertz, 1 year, 6 to 7 hertz. That is the posterior dominant rhythm. So very young infant, say 1.5 month old infant, what do you see here? So they are looking little sharpish. You may confuse them with sharp waves or polysharps, but these are unilaterally expressed sleep spindles. So this is the earliest stage you can see sleep spindles being formed. And again, the same activity is also represented in the midline electrode, right? If you can appreciate. So you can have unilateral spindles in one page, and another page you will see it on the other side. So this can happen. This is very common in infants. Okay. So again, spindles mainly expressed on the one side, but other side it doesn't show much, some reflection of same thing. Again, the distribution of spindles may be little more broader than in older children. So older children, typically you have it in the frontocentral regions like front F3, C3, F4, C4, FP1. But in young infants, you can have it much more wider distributed. So sometimes you can see as wide as even parieto-occipital region also. So this is another difference in young infants' sleep spindles. Then sometimes you can have only one hemisphere expressing the sleep spindles, but in the central regions you can see it throughout. Okay, so unilateral expression is not abnormal, but it keeps changing between the hemispheres. So as I said, 4 months is a landmark age for understanding many aspects of maturation. So in newborns, the sleep states are different, active sleep and quiet sleep. So instead of REM sleep in newborns, we call them as active sleep. NREM sleep is quiet sleep. This is for newborns. I'm not talking about infants. So that neonatal pattern where awake in newborn goes into active sleep, that is REM sleep, which is kind of narcolepsy, right? Older child, if they go into REM sleep directly from awake, you call it as narcolepsy, but that is a physiological thing in newborns. So from this pattern of transition from awake to sleep, at around 3 to 4 months, they start going into NREM sleep instead of REM sleep equivalent. So that is one major change in the transition from sleep, awake to sleep. Second important milestone is anterior to posterior gradient starts appearing at 3 to 4 months of age, right? So awake to sleep, they go into NREM sleep starting from this age. Anterior to posterior gradient starts to be seen from 3-4 months of age. So at this age, the posterior dominant rhythm is 3.5 to 4 hertz. So remember these 3 points. So nearly 3/4 of infants, you have this 3.5 to 4 hertz PDR. Then sleep spindles will be seen by 2 months itself, and vortex waves just start appearing. So this is a 4-month-old infant awake state. Can you appreciate the gradient between the posterior regions and the anterior regions? Can you all appreciate? So here the frontal is much more flatter with some fast beta components, whereas posteriorly you have nice 3.5 hertz dominant rhythm, right? More better modulated activity. So this is the earliest PDR that you see in a 4-month-old infant, right? So same thing in a average referential montage, you can see nice posterior dominant rhythm. In younger children, you can check reactivity by doing what is called as visual blocking response. So, instead of eye opening, eye closure, because infants may not follow what you say, you do passive eye closure. You just put your hand over the face without actual touching or closing. Just by blocking the vision can make the PDR appear. So that is reactivity. So this is equivalent to eye closure. Visual blocking is eye closure. So just put your hand in front to block the vision. There is appearance of PDR. Once you remove, the PDR is gone. So this is like a attenuation of alpha that you see in older children. Then the spindles are much more widely distributed. If you can appreciate, although they are dominant over frontocentral regions, but you can see them as far as temporal and occipital also. This is one important difference in infants. Then the other important thing about spindles is they can be asynchronous. So here in the first half of the page, you can see spindle predominantly on the right hemisphere, central parietal regions. After about 2-3 seconds, you see it on the other hemisphere, right? So there is asynchrony. They are not coming at same time point, but in the midline, they are expressed throughout, if you can appreciate that. So this asynchrony is a very much normal phenomena in infants. Up to at least 18 months of age, you can have asynchronous spindles. So as they grow older, more and more spindles become synchronous, and beyond 2 years, it is definitely abnormal to have asynchronous spindles. Okay. Then K complexes, they just start begin to appear at 4 months of age. You can see. So it is not like a classical K complex that you see in an older child. You may not appreciate all the elements of this triphasic waveform, but you see that it's a broad waveform with more than 2 phases and preceding spindles here, or you can have following spindles also. So that is one of primitive K complex in a 4-month-old infant. The other thing is you can have spindles which look little spiky, right? In an older child, we have seen some of these rhythms look like mu rhythm, right? Like spiky face on one side, other blunted morphology on the other side. But this is a normal for infant spindles. Okay. So the other important background appearance is this occipital slow waves. Can you see these sharp looking waveforms, right? They look something like a cone. So these are called cone waves. So you have occipital negative sharp looking waveforms which are present in both occipital regions in a NREM sleep stage. So these are called cone waves. Again, this is a normal physiological element of the background in sleep for an infant. So don't report them as abnormal sharp waves. So coming to 1 year, the background comes to posterior dominant rhythm in awake state comes to 5 to 6 hertz. In sleep, you will see good bilateral symmetric sleep spindles, but can have asynchronous till 18 months of age. The vortex waves become more and more well organized and better appreciated by this age, and same with the K complexes. So again, good posterior dominant rhythm, but as you can see, 1, 2, 3, 4, almost 5 hertz posterior dominant rhythm, well modulated activity, and hypnagogic hypersynchrony. This also we have seen in the morning session. There's very good drowsy burst. You can see generalized delta to theta range activity, and the younger the infant, more prominently you will see this hypnagogic hypersynchrony. Again, if your filter settings are not appropriate, the technicians may make them look like spike waves. So especially these ones, right? So this is also another example of hypnagogic hypersynchrony. So if you count them, it is about 1, 2, 3, 4 hertz. So theta range activity, which is more in the frontocentral but can be seen generalized. So if your low frequency filter is set at 3 hertz or 5 hertz, they may look very spiky. So you may report them as generalized spike wave. So, but this is a normal physiological finding in an infant. So the other thing is spiky spindles. Again, very common in infants. So they look sometimes unilateral, very spiky. But important thing is that they are expressed in the midline also, and the frequency. So spiky or comb-like spindles are very much normal finding in an infant. Then asynchronous spindles and K complexes are other finding which can be seen in a 12-month-old. So here a K complex, but not very classical, but more broader distribution preceding sleep spindles, more triphasic morphology that will tell you to identify K complex. So vertex waves at 1 year, they are more or less same as what you see in an adult or older child. So 5 years, nothing much different from older child now. So most of the elements that you see in adult EEG have already been established. So most children would have reached alpha range background rhythm by this time. You can even start seeing mu rhythm in the central regions. Posterior slow waves of youth we have seen in the morning session that can be seen. But important in activation procedures, hyperventilation can produce very good physiological responses like generalized slowing can be seen best at this age. So sleep activity is almost same as in older children. So I'll not go into 5-year-old, just to highlight hyperventilation can give very good slowing response, which is generalized normal phenomena. So just to sum up the maturation in awake state, so in a 4-month-old, we have seen this is one important age to remember. You have anterior to posterior gradient starts appearing at 4 months of age. You have PDR as early as 4 months, around 3.5 to 4 hertz. Then you can have by 1 year, you have 5 to 6 hertz PDR. Then by 5 years, most children, more than 80% will have alpha range background rhythm. And you can have normal elements like posterior slow waves of youth start appearing in the childhood. Whereas in sleep, you have more broader waveforms, vertex waves in a young infant, then more sharply contoured as the child grows to 1 year and 5 years. And in spindles, you can have asymmetric and asynchronous spindles in a young infant starting as early as 2 months of age, and they are more spiky in younger children. And as you grow older, the distribution becomes more narrower into frontocentral regions. They become less spiky and more synchronous. So that's how the spindles evolve over age. So that is about infants EEG. So briefly, we'll see the neonatal EEG. So the main difference is in the montage that we use. So you have less number of electrodes in a newborn as compared to older child. The reason is the small size of the head. So you have only FP1, FP2, then T3, C3, C4, T4, and O1, O2. That's all. Then you have these midline electrodes. So you have less electrodes as compared to older child. There are additional channels which are extracerebral. What are those extracerebral? One, you have for eye movement to record on both the eyes, eye movements, side to side eye movements. Then chin electrodes, because many times they have chewing or sucking movements which can confound the cerebral activity. Then you have respiratory and cardiac monitors, and sometimes limb movement electrodes also. So surface EMG for limbs as well. So that makes it almost like a polysomnography. You have all the respiratory, cardiac, limb movement, every sensor like you do in a sleep study along with the cerebral electrode. So it's essentially a PSG, polysomnogram. So just we'll try to understand the salient differences between how we look at a neonatal EEG versus a older child. So the only thing that will interpret differently is the background description. So instead of posterior dominant rhythm, symmetric synchrony, the important terms that we use is continuity, discontinuity. This is one important difference. Then the sleep states are named differently in a newborn. So instead of REM sleep, we call it as active sleep, whereas NREM sleep equivalent is called quiet sleep in newborns. So remember these two differences. So background dysfunction, continuity of background or discontinuity is an important parameter when you describe the background. And sleep states, other than awake, you have active sleep and quiet sleep. And as I mentioned earlier in the talk, newborns go from awake state into REM equivalent, that is active sleep. So it's kind of narcolepsy. Then quiet sleep happens after the active sleep. So awake, active sleep, and then quiet sleep. So this is one whole cycle. So typically this cycle from active to awake to active sleep, quiet sleep, and again coming back to either active sleep or awake, this takes nearly 60 minutes. So that's why to capture all the states, newborn EEG should be at least 60 minutes. So this is important, right? So in typically in adults, you have short 5 minutes, 5 or 10 minutes awake EEG and 20 minutes sleep EEG. But in newborns, you need to have at least 1 hour EEG. So this we have discussed already. So active sleep, quiet sleep, just I'll spend a little bit here. So in active sleep is, what is the equivalent in older children? Active sleep, REM sleep, right? So REM sleep, eyes are closed because it is sleep, but there are body and limb movements, rapid eye movements are there, and breathing is irregular. Okay, remember this. Whereas quiet sleep, eyes are closed, breathing is regular, not much of body movements and not much of eye movements. So many times instead of looking at cerebral activity, we may have to look at the extracerebral electrodes to see whether this is active sleep or quiet sleep. Okay, so as you can see here, the polygraph shows that there is some irregular breathing. Can you appreciate? So this is a respiratory, green channel is respiration, blue is chin movement. So there was some chin movement and some breathing irregularity. And the EEG will be continuous. Okay, just remember this slide, we'll come back to this. So active sleep shows continuous record. So again, some movements, that's why there is some artifact. Breathing is irregular. Some eye movements, can you appreciate? So these two are left and right eye electrodes. So there are eye movements, irregular breathing, but the record cerebral activity is continuous. So this is active sleep. Quiet sleep looks like this. So breathing is regular. You don't see any deviations on the respiratory channel. There is no chin movement. Eye movements are also not there. This is ECG artifact which is superimposed on many channels. But otherwise, there are no eye movements. So breathing is regular, no eye movements, and the EEG is discontinuous. Can you appreciate the discontinuity? Right? So in the beginning, you have about 3.5 second activity, which has a higher amplitude and various mixed frequency activities, some sharper elements, some slower elements superimposed. That is a burst. Then there is another burst in the end of the page. But in between, you call it as a suppression period or interburst interval. That's the appropriate term. So you have burst and interburst interval. So this discontinuous record is very characteristic of quiet sleep. So this is a normal finding in a quiet sleep in newborn. Okay. So you measure or describe the morphology of burst and the amplitude and duration of the interburst interval. That will tell you whether this degree of continuity is normal or abnormal. Okay, so first thing is background description. You have to comment on continuous or discontinuous record, whether all sleep states are present or not. So we have seen how does active sleep look like. So that's a continuous record with some eye movements, body movements may be there, breathing is irregular. Whereas discontinuous record with regular respiration, no movements of the body or eyes, that is quiet sleep. So if you have awake record, active sleep record for the part of the EEG, then you have a quiet sleep for a few minutes, all the sleep states are seen, then you can say good state to state variation is there. So this is one important comment you should always make when you are looking at neonatal EEGs. So the amount of discontinuity is a matter of gestation, right? More premature the baby, more discontinuous it is, right? So the amount of discontinuity here, typically if you see in this page, 1, 2, 3, 4, about 4 seconds discontinuity. Our interburst interval is 4 seconds. This is clear? So in a full-term newborn, up to 4 seconds discontinuity is normal. And we also look at the amplitude of these discontinuous periods. If it is more than 25 microvolts and if it is less than 4 seconds, this is normal degree of discontinuity for a term newborn. So many times if the discontinuity is much more, we have to compress the EEG to see how many seconds it is discontinuous. Here this is almost 10 seconds. Okay. So we'll not go into the detail, just to understand how it evolves. In a very preterm baby of 26 weeks, the discontinuous periods may be as long as 14-15 seconds. So you will have low amplitude periods going up to 15 seconds or longer, and then there is a burst of mixed frequency activity. So that is burst and interburst intervals. As the gestation goes towards full term, the discontinuity reduces, interburst interval reduces, and the EEG becomes more continuous. So there are two terms you need to remember in the discontinuity: trace discontinue and trace alternance, right? So trace discontinue is, it's a quiet sleep pattern. So it is a discontinuous record where you have bursts of higher amplitude burst with mixed frequency activity, and there is interburst interval, but the interburst interval amplitude is less than 25 microvolts. Okay, so this is seen in much preterm newborns like 28 or 30 weeks or 32 weeks newborns. You will see what is called as trace discontinue or discontinuous tracing. Important thing is the amplitude of interburst interval is less than 25 microvolts. Then there is another pattern more towards the term gestation around 36-37 weeks, that is also discontinuous, but only difference is the amplitude of interburst interval is more than 25 microvolts. Is that clear? Trace discontinuous more preterm baby where the amplitude of interburst interval is less than 25, whereas towards term gestation the amplitude is more than 25 microvolts. So this is one key difference between trace discontinue and trace alternate. So this is a trace alternate. Then the more once there is complete full gestation or full term gestation, the record becomes continuous instead of discontinuous periods in quiet sleep. Now whole of the record, active sleep, quiet sleep, cannot be distinguished. It's a continuous record, that is called as CSWS. So this is not abnormal. This is continuous slow wave sleep. That's all. It is not spike waves. So this is a continuous slow wave sleep, right? You can see, you don't see any discontinuous or suppressed periods now. So this is a marker of full term gestation. So we'll not go into the synchrony. So from very preterm baby of 28 to 40 weeks, what things change? One, sleep states become more well organized, like quiet sleep, active sleep, they become more well organized towards full term gestation. Quiet sleep, initially you have trace discontinua in a very preterm baby of 26, 30, 32 weeks, whereas towards term gestation you have trace alternate, and then you have CSWS pattern. So these are all normal elements of a quiet sleep. So I think I'll stop it here. So only the last slide. So sometimes frontal sharp waves can be physiological, right? In newborns, we don't really search for spikes. So spikes is least of our concern in neonatal EEGs. The more importance is given to background description, whether the background is appropriate for that gestation or is it excessive discontinuous or low amplitude. That is a major concern. Second is to identify any electrographic seizures. So these are the two main indications that we do neonatal EEGs. Any sporadic waveforms, even if they are looking sharp, most of the times it doesn't have any clinical implication. So you can have physiological sharp waves which are called as encoches frontalis or frontal sharp transients. These are absolutely normal finding. So you don't have to report them as frontal spikes. Okay. So I'll close it here. We'll have few EEGs. Lakshmi can.
Yeah. Let us do the newborn.
Okay. Yeah, this one.
So we'll briefly read some of the EEGs, live EEGs. So this is a typical neonatal montage, what Dr. Ramesh has already described. So one main difference is like you have the same page. Here you have a longer inter-electrode distance. Basically, the longer the inter-electrode distance, the amplitudes will be better. So the newborn EEG, the amplitudes are much slower, much lower microvolt. Okay, so you have a longer inter-electrode distance to capture that smaller activity. The same thing what you do in a electrocerebral silence. You have a longer inter-electrode distance. Similar montage only you use for electrocerebral silence also, like FP1, C3, O1, FP1, T3, O1. That's all, right? So, and another important difference here is you have the transverse chain also in the same montage. This is one important difference compared to the older child. So you have a longitudinal chain, double banana, but with a smaller number of electrodes. But you have the same page, you have A1, T3, T3, C3, C3, C4, C4, T4, and A2. So transverse chain also. Why this is important? Most of the activity happens around the central vertex region because that is the highly myelinated region. In a term newborn, the central perirolandic cortex is the myelinated cortex. So that is where most of your EEG activities happen. So you can correlate the activity in the transverse as well as longitudinal montage. So we keep these side by side in the same page, apart from the polygraphic channels that we described. Okay. So since the neonatal EEG we have seen at the end of this presentation, so we'll see one recording where we see the live reading session of the neonatal EEG before we move on to slightly older age group. So here you can see, so is it continuous or discontinuous EEG? This is continuous, okay? So we are clear about what is continuous, what is discontinuous. Okay, right. So I'm going to go forward. Let us see, is there any discontinuity at any point? Okay, what do you see here? So there is a sharp transient in the bifrontal region. Okay, so that is the last slide what Dr. Ramesh showed. This is the frontal sharp transient, which is normal for a newborn baby. You should not report this as a frontal epileptiform activity. For a newborn baby, frontal sharp waves is a normal physiological. The French term is called encauché frontalis, but you can call it a normal physiological frontal sharp waves. And similarly, you have a frontal dysrhythmia, that is a frontal delta slow wave. That is also normal variant. You can have a frontal slowing like your Frida. You can have a frontal sharp wave, which is normal physiological in newborn baby. Okay, so that is a good example for frontal dysrhythmia as well as frontal sharp wave here. Still, predominantly the EEG is continuous at present. And another example for frontal sharp transient here. And if you see bilaterally, all the waveforms you are able to see, whatever waveforms here, you can see waveforms here, right and left. So this is a synchronous symmetrical EEG. So that is another important aspect that we will describe. So I'm going forward to see is there any periods of discontinuity. This is another frontal dysrhythmia and frontal sharp wave, which are normal. So this is another page where you have a frontal sharp transients. Sorry?
Delta brush.
Okay. Was it there?
Before this, there was delta brushes.
This one. Okay. So these are what are called delta brushes. So the extreme delta brushes basically came from the neonatal EEG only. So in a physiological newborn baby, especially more preterm baby, you have a delta wave. Especially on the ascending limb, you have a faster activity, alpha beta fast activity, that is called delta brush. This is a good example for that. So you have a delta wave here, and on top of that delta wave, you have a beta frequency fast activity. Okay, so this is a marker of preterm baby. It's a normal finding, unlike your encephalopathy pattern, where the delta brush, extreme delta brush is a pathognomonic feature or pathological feature. Here it is a normal physiological feature. So you have to identify delta brushes are there, which is a marker of prematurity. In a term newborn, you will not see delta brushes. So this is the only importance, and this is not abnormal for this age. So there are other examples here, delta brushes. Yeah, at present, Suddenly, now you are coming across a page where there is a burst of activity which are little bit higher amplitude, and relatively lower amplitude activity is there for few seconds, and another burst starts here. Okay, so this is discontinuous. Till now we saw pages which were continuous. So in a preterm baby, continuous periods are seen during awake, during REM sleep, during active sleep. So awake and active sleep are usually continuous. The quiet sleep is discontinuous. Okay. Now looking at the discontinuity, so this is 50 microvolt sensitivity. So look at this activity. Are they more than 25 microvolt or less than 25 microvolt?
More than.
Looks like more than 25 microvolt. The sensitivity is 50 here. Okay.
Trace alternance.
Yeah, and these are short interburst interval, 3 seconds, 4 seconds, so shorter interburst interval, higher amplitude activity during the interburst interval, and burst of activity, discontinuity. This is trace alternate. So this is a more towards term baby. So that's what we are seeing. So this is periods of discontinuity. At the same time, this is another period of discontinuity. You have 1, 2, 3, 4, 5, 6 seconds of interburst interval, and you have a burst here with multiple different mixed frequency activity, delta and alpha activity here predominantly, and another burst here, right? And if you look at the polygraphic channel during this activity to classify whether it's active sleep or quiet sleep, the respiration is regular, there is no irregularity there, and ocular channels are not showing any eye movements. Okay, so there are no eye movements, there are regular respiration, that means it is a quiet sleep. Okay, NREM sleep equivalent, quiet sleep, so you don't have eye movements, your respiration is regular. So from the EEG also we can appreciate this is a discontinuous period, possibly it is a quiet sleep, and that is confirmed by no eye movements on the ocular channels and regular breathing on the respiration. So this is how we classify each page. How you classify each page in your polysomnography, whether it's N1, N2, N3, or awake or transition like that. In newborn EEG also we do that, whether it is awake period, active sleep, or quiet sleep. Depending on that, we describe the EEG. So going forward, more pages of discontinuity. You can see in between there is a burst of higher amplitude activity followed by relatively lower amplitude activity for 3 seconds, 2 seconds. So this is again trace alternance. So till now in these terminologies or in these newborn EEGs, any specific doubts? Anyone didn't understand anything? So the newborn EEG is very difficult, and there are a lot of things are there. We try to simplify, we try to show you some of the salient points what we can describe. So if there is any specific questions, you can ask. We'll go to old age. Anything else? So as Dr. Ramesh was saying, the background should be described, and here in the newborn EEG, the purpose is not looking for focal epilepsy abnormalities. Here we are looking at background abnormalities, discontinuity, maturity, symmetry, synchrony, and is there any electrographic seizures. These are the predominant features what we are looking at in the newborn EEG. So this is much different than older age group. Okay. So then we'll stop here and go to a older age group EEG. Okay, so we'll see this one. Right. So this is a young infant. So from the first page, you can see a lot of the features that already were described. So what are these? Sleep spindles. So here it is bilateral synchronous, but in a young infant less than 18 months, many times the sleep spindles are asynchronous. That does not mean it should not be synchronous. Okay, so many times it is synchronous, many times it is asynchronous, which is physiological for this age group. So in this page, you are seeing bilateral synchronous sleep spindle. At the same time, towards the end of this page, you have only the right-sided spindle, which is longer, which is more sharp and spike-like activity. Okay, so these are the characteristics of the baby spindle, what we call baby spindle, more younger infant. Okay, and in the same page, the next page, you can see the spindles are more unilateral on the left side. Previously we were seeing right side, now it's left side, and in the middle there is a bit of right side, then again at the end there is a left side. So this is how it keeps alternating between right and left, right and left. So if you want, some people go, okay, there are 100 spindles, 50 right side, 50 left side. So you can say, yeah, they are symmetrical. Even though they are asynchronous, they are symmetrical. Okay, the number of spindles on the right and left are almost equal, right? But we don't go counting and all, we roughly see whether they are equal. And here, what you see in between? So this is a sharp delta activity in the occipital region with a negative polarity. So this is the cone wave. So this is the earliest age that you can see some cone wave, and usually the posterior delta activity is of higher amplitude. So this posterior delta activities are higher amplitude all throughout young infancy and childhood. So this should not be taken as a occipital slowing. In a sleep EEG, occipital delta activities are higher amplitude. Okay, occipital higher amplitude delta activity, which is normal for infants and young children sleep. So this is a very normal finding. Many times this is abnormal, reported erroneously as abnormal. This is a very nice spindle again, and it is bilateral symmetrical at this point, synchronous. And these are again more cone waves and delta waves. So this is earliest your K complex. Okay, so more widespread waveform and with some phase reversal. So I'm going forward just to show you a feel of how a young infant EEG looks like. So now we are going into a phase where it is more delta sleep. So there is a NREM3 equivalent. You have that in this age group also, 5-month-old showing more delta sleep now. Okay. Right. So this is a very good example for cone wave. So very short delta activity. Sometimes it can be uniphasic or sometimes it can be biphasic like this one. Okay. So we'll go forward. Yeah, this is a very good example for K complex. You have a biphasic waveform, widespread, almost generalized with phase reversal in CZ, C3 and C4. Okay, so this is the earliest K complex that you can come across. So in pediatric age group, one important aspect that you have to remember is many times the physiological sleep markers are very high amplitude, especially the K complex and vertex sharp transients. So especially if you see this in a paper printout, you will think because of the overlapping nature of these waveforms, you will think that this is a generalized sharp wave or generalized spike wave abnormality. Okay, this is the most common mistake people do, and they report all these physiological normal activity as epileptiform abnormality. So this is the most common error that happens in a pediatric EEG reporting. So amplitude alone doesn't mean anything. So you have to adjust the sensitivity. Better you report all this EEG in the system, not in the paper printout, so that you can adjust the montage, adjust the sensitivity and see for yourself whether it is a normal physiological activity or pathological activity. Say for example, here you have a very high sharp contoured delta activity in the posterior occipital region, which is normal for this age. So this is not epileptiform, this is not abnormal slowing. This is a normal activity for occipital region for this age group. So we'll stop there, and final one EEG will show. Yeah, so this is slightly older, nearly 2-year-old child. Okay, so this is a sleep activity, sleep pages. So what we are seeing, we have a, so it's already 150. I'm just adjusting the sensitivity. Now this is 70. Now you can see they are all higher amplitude activity. In 70 it appears very tall, and you have some cone waves, you have posterior sharp delta activity, and it's a very fast rhythms, more beta and alpha frequency activity most of the times. So this is sleep EEG, but it's a mixed frequency, beta predominance with the theta and delta activity coming in, right? And this is a K complex here. This is one K complex. Again, this is a young infant, 2-year-old. So the K complexes are not that well formed, but you can appreciate they are higher amplitude, biphasic, diffuse, almost generalized waveform. So easily this can be mistaken for epileptiform activity. So this is the posterior sharp delta activity we were describing. Some of these are the cone waves, and sometimes these are the good examples for the posterior delta slowing, which is normal physiological. So many times beginner, inexperienced EEGer report this as occipital slowing or occipital spike. Okay, so that is a importance why we need to identify this as a normal physiological pattern for this age. Look at this page. If I just remove that. Okay, see, this is a K complex. Okay, and this is very high amplitude, right? So it is overlapping and appearing like there are some faster components here, but these are physiological K complex only. So sometimes, especially in a 3-year-old, 4-year-old child, the vertex sharp transients can be very spiky. So that is another common mistake people do. They report, so these are some of the spiky vertex sharp transients. They report that as a central spike or epileptiform abnormality. So this is again a higher amplitude delta posterior occipital slowing, which is physiological normal. And the sleep spindles, you can see for a 2-year-old, so how these are very well localized to central regions. This is another sleep spindle. Okay, so this is looking more like an older child only, central parietal region, more localized, more shorter compared to the young infant where you had a longer sleep spindle. So this is another high amplitude activity, biphasic, phase reversing CZ, C3 and C4, and this is K complex. Okay, so it may be that we are just emphasizing and repeatedly saying the same things, but these are the most common errors that happen in the pediatric EEG reporting. That's why we are overemphasizing on these points. So above 3-year-old EEG is almost like your older child or adult EEG only, but less than 3-year-old you have to be very careful about these higher amplitude waveforms, especially if you are looking at paper printout EEGs. Anything more? So any specific questions in the pediatric EEG? Anything you didn't understand? Anything you want to clarify? Anything you want to ask? Okay, up to what age?
Usually below 2 years, 1-2 years usually.
Yeah.
Below
So-
1 to 2 years.
Okay. So anytime you can ask us the questions like through the WhatsApp and through the WhatsApp groups. Thank you once again. Thank you, Dr. Atmanam sir, for having us here and wonderful hospitality.
Thank you.